Hey, Rebels. Welcome back to Rebelcast, your go-to source for critical appraisals and the latest in knowledge translation of cutting-edge medical research in emergency medicine and critical care. I'm Mark Ramsey, an emergency medicine and ultrasound-trained cardiothoracic intensivist, joined by my good friend and regular Rebel contributor, an awesome intensivist, Dr. Frank Lodeserto. Thanks for joining, Frank.
Thanks for the intro, Mark. I'm a pediatric and adult intensivist. I'm also a residency program director, so I love talking about evidence-based medicine and educational topics like this. I'm really happy to be recording with you, Mark, on one of my favorite topics. We're here to break down today's hot topic, DKA, with a little bit of a twist.
That's right. Today is part one of our series on DKA, and we're going to dive deep into the SQuID protocol. That's subcutaneous insulin in diabetic ketoacidosis. It's not your typical approach, but definitely one worth examining.
Traditionally, we've used IV insulin drips for all DKA, which means ICU admissions in most hospitals. Now, you may be at a hospital that does allow insulin drips in a step-down unit, but generally, a lot of these patients go to the ICU, which also means long ED stays, tons of nursing resources. But the SQuID protocol asks the question, can we manage mild to moderate DKA outside the ICU with subcutaneous insulin?
Yeah, and let's back up. DKA management generally follows a triad of fluids, electrolytes, and insulin, but not every DKA is created equal. Mild to moderate cases might not need full-level ICU care, and that's where Griffey et al. Explored in their quasi-experimental pre- and post-trial.
Exactly. They implemented the SQuID protocol in a busy urban academic ED. For eligible patients, they gave subcutaneous fast-acting Lispro every 4 hours. They also gave a long-acting basal glargine at time 0 and fluids as needed. They compared that with the traditional insulin drip pathway.
And it's important to know who was included in this trial exactly. So adult patients who met the criteria for mild to moderate DKA meant that they had glucose levels greater than 300, positive ketones, and ion gaps, DKA as a discharge diagnosis, and they had received insulin, of course.
Right. They excluded severe DKA, defined as a bicarb less than 10, pH less than 7. They also excluded pregnant patients, those with altered mental status, end-stage renal disease, CHF, serious infections, surgical candidates, and anyone deemed too sick for the floor.
And that's really important to note, Frank. A lot of their exclusion criteria were patients who had a lot of comorbidities like altered mental status or end-stage renal disease, CHF. These are all things that can trigger DKA. And certainly our DKA patients are not always the healthiest. And so as a result, there weren't that many patients in their study. And what stood out amongst the 177 mild to moderate DKA patients were the following outcomes. Their ED length of stay dropped by about 3 hours in the SQuID group. And so that went from 8.9 hours versus 11.9 hours. Interestingly, there were no major differences in safety. So the hypoglycemia rates were similar amongst both groups. And then lastly, the ICU admission rates were lower in the SQuID group. Only 5 out of the 78 patients required ICU level of care.
Yeah, to me, that's the biggest takeaway. The protocol didn't just save time, it actually saved ICU beds. That's a huge deal, especially when your ICU is limited or it's full. Now, with that said, a 3-hour reduction in ED length of stay might not seem like a huge deal at first glance, but if you've ever worked on a busy ED shift, like you probably have, Mark, trying to move patients to floor or to the ICU, you know how valuable 3 hours can be. Still, it's a modest operational win.
Yeah, and I literally yesterday walked into a 7 a.m. shift where there were 4 ICU boarders. And if one of them was a DKA patient, this would have been extremely applicable. I could have easily had them admitted to the floor as opposed to waiting for one of the ICU beds to open. And what I later learned out actually from one of my intensivist colleagues was actually a couple of the beds are under construction. So that's why there are 3 or 4 beds that weren't immediately available. And those are the 3 or 4 beds that happened to be in the ER at the time. So I totally agree. It's promising, but we also have to consider some of the limitations. And one of the limitations in this was that it's a single center trial. Nurses didn't strictly also follow the 2-hour glucose check rule. They defaulted to the hourly checks, just like any IV insulin protocol would require. Now, here's the other catch too. From a nursing workflow standpoint, this actually didn't decrease the workload at all, right? If nurses are going back to those hourly checks, then it actually has no impact on nursing operation workflow at all, and the workload is essentially the same.
Right. You would have thought the nurses would love this, checking every 2 hours, but the study showed they still checked every hour, probably out of concern for hypoglycemia, which again, if you looked at it, there was a very low rate in both groups, the insulin infusion and the subQ insulin of hypoglycemia. The one thing I didn't hear is patient comfort. I mean, I'm thinking no one wants to get stuck with subcutaneous insulin every 4 hours for a day or so, depending on how long it takes to correct. It's probably not fun for the nurses either to drop that insulin and inject every 4 hours and all the charting that goes with it. That's a lot of work.
Yeah, and one really quick point I want to throw in there, Frank, is we often sometimes get a little lost in how the patient feels or overlook that sometimes. I mean, you and I both know from an intensivist standpoint, being in the ICU is certainly not patient centered. I mean, they don't get sleep in the middle of the night, they're being woken up at all different times, they're really at high risk for delirium. And this is just another factor to be considered. If a patient's getting stuck multiple times for a subcutaneous injection, for insulin, that's completely separate from the heparin subcutaneous injection that they're getting for DVT prophylaxis. These are all factors to consider in addition to the workload on the nursing staff and why it might not be very straightforward to implement this kind of protocol.
Yeah, absolutely. Now, anecdotally, this before, without the data, we've had some patients in pediatrics, particularly, where all DK comes to the pediatric ICU. But I've talked to their pediatric endocrinologist, and we actually, in very mild cases, have given subcutaneous insulin. I didn't have the data to support it, but they corrected pretty quickly. We thought it was just a waste of an ICU bed for this kid who's going to correct within hours. And, the subcutaneous did correct them. I'm glad now I have a little bit of data to support that. It just seemed to make sense at the time. But I want to also talk about one thing that really confuses, I think, our nurses and even our internal medicine residents is insulin infusions and what are we focused on in DKA. Our residents sometimes get lost and our nurses get lost following glucose levels, thinking if I can get the glucose normal, their DKA is corrected. And that's not what's going on in DKA. The point of DKA is understanding the biochemistry, not just blood sugars. Here's how I explain it to my residents. In DKA, the body can't utilize glucose as an energy source to make ATP, so it switches to ketosis, breaking down fats, which leads to acid buildup and what gives you your anion gap. Insulin is what shuts down ketosis. The blood glucose may drop quickly, and usually it does. Especially, I know I have adolescent patients that inject themselves because they know they have been non-adherent to therapy, and they come in with lower glucose levels, but really high anion gaps. So that blood glucose will get corrected relatively quickly, but it takes longer for the anion gap to close. So that's the real marker for success is closing the gap. And if you titrate the insulin drip based on the glucose, you're not addressing the actual underlying problem. The correct approach is to fix the insulin drip by adding dextrose once glucose drops less than 250 and not shutting off that insulin. So this is where our nurses get a little tripped up. This is where the residents get tripped up a little bit. And I understand that the insulin drip can cause hypoglycemia. There's a major concern, particularly if patients are going outside the ICU. They're going to be on an insulin drip and it's going to be titrated for glucose. In studies, that has shown that it actually slows down the correction of DKA, but it is more safe for patients to titrate for the glucose, even though it may slow down or it may take longer for you to correct that DKA.
That's interesting, Frank, because my theory behind why I think nurses and residents are so driven on the blood sugar is because it's a immediate gratification test that can be obtained at the bedside, right? A finger stick, it shows you number, you kind of know where you're going with your insulin drip. Whereas having to wait for that chemistry and the anion gap and all those labs to come back, that takes time. And they want to be able to see the results of their therapy immediately after being initiated. So it's partially not surprising, but it's also really important to emphasize that the DKA is all about the biochemistry and not just blood sugar. So, I mean, from your experience as a pediatric intensivist, is there kind of a different system or something that you guys use that might make it more streamlined or efficient?
Glad you asked, Mark. Yeah, we do. We have something called a two-bag system. And I don't know if you've ever rotated in the pediatric ICU as a resident, but it confuses people, this two-bag system. So let me explain the two-bag system if you've heard of that before. Basically what it is a bag of D10 plus electrolytes and another bag, the other bag system, it's just electrolytes without any dextrose in it. Now, the physician puts an order for a fixed dose of insulin. That is not changed. But what the nurses actually do is they'll initially run the electrolytes. And that could be LR, that could be normal saline, that could be half normal, or some weird concoction of fluids that the pediatric intensivist comes up with. But we have that same bag also with D10. And what the nurses do, as the blood sugar starts to drop, and we know that they have a large anion gap, is they'll start adding some of the D10 with the electrolytes, giving you a D5 mixture. If the blood sugar drops too much, then they'll stop the electrolyte with no dextrose in it and just add the electrolyte mixture with D10 in it because they don't want to shut off that insulin drip. The pediatric ICU nurses and the pediatric physicians are well trained to know it's about the anion gap and not about the blood sugar. So we keep that insulin drip going. We actually add dextrose in there until that gap is closed. Now, there are times to stop it, maybe if the potassium drops too much or they get hypoglycemia, but the hypoglycemia rarely happens just because we have that two-bag system and the ability for the nurses to do it themselves. It gives them that autonomy to add the dextrose when that blood sugar is dropping too much.
That's actually really cool. That's pretty awesome. I personally did not rotate through a pediatric ICU. I did through a neonatal ICU, but I'm curious to hear your thoughts on what this does for volume intake. So is this a larger amount of volume because it's a two-bag system, or has it been kind of relatively adjusted on each bag to the patient's needs?
No, a little bit of that is a discussion at the bedside. So depends how much. If you think they're dehydrated and you volume resuscitate, then you can either run it at maintenance or maintenance a half, depending if they're a little behind. You're going to give the insulin drip, and generally speaking, the adults are even on some kind of maintenance fluids because of the electrolytes. So I don't think it lends to more fluid. It just really depends on the patient and the resuscitation process.
That's interesting. Yeah, I think it's definitely a workflow win. I mean, it seems like it's more efficient for both the biochemistry resolution that the patient is experiencing with their DKA, and then also the workflow and the operations of the ICU with regards to nursing. Adult DKA management can certainly learn from this. I know my ICU I work in, one of them, we don't do this two-bag system. We do that maintenance fluid kind of approach in addition to the insulin drip. So we could certainly learn a lot from this for sure.
This is the one thing as a med peds physician is you see it all the time in peds. It's so standard. But if you talked about a two-bag system on the adult side, I think heads would explode. They have no idea what we're talking about. But it's amazing how in the same hospital you have two systems going and no one communicates. But this is where I think the pediatric intensivist or the pediatric ICU gets it right. And definitely the adult ICU can learn from it. It may take a lot of education to get there. So I don't see this happening overnight, but still a great thing that I've gotten from pediatrics that I try to bring to my adult colleagues, but they, I think, ignore it. It's a little too complex of a system to implement.
Practice and culture change is hard, my friend, for sure. So Frank, tell us what's the bottom line of the SQuID protocol and the study in general?
Yeah, so bottom line, SQuID protocol looks safe and it dramatically reduces ICU admissions. Just 5 patients in the SQuID arm needed ICU compared to 99 in the traditional group. That's a big deal if you're short on beds or have no ICU beds left and your patients are boarded up in the ED.
Yeah, and it's important to remember that it did not reduce the nursing workload. Nurses were still checking glucoses hourly, and they were still going into rooms every 2 hours to give injections. Let's be honest, subcutaneous insulin injection every 2 hours doesn't feel great for the patients, as we talked about. And it's also important to keep in mind all of the other things the patients might be getting. I mean, if nursing and the physician team were really cognizant and intentional about this, they would line up a lot of these things together, like the subcutaneous injection for DVT prophylaxis and any other things that they have to do on an hourly or Q2 hourly basis.
Yeah, I'm not opposed to trying this protocol, especially when ICU beds are tight. And like I said, I've kind of done a version of this protocol, particularly in mild DKA patients, where I know they'll correct within hours on insulin drip. So it made sense to do subcutaneous insulin. But again, it takes protocol, discipline, and nursing comfort, and really good communication between departments, emergency medicine, the floors, ICU, to really get good buy-in on this. And I'm curious about patient discomfort. It wasn't mentioned in this trial. It seems like a lot of injections, but at the same time, they corrected within a shorter period of time and didn't need the ICU. So that may outweigh the benefits here of getting injected with insulin every 4 hours.
Yeah, to your point about also interdepartmental buy-in and communication, I mean, our hospital would look to streamline the DKA protocol that was initiated in the ER and have it continued in the ICU. And so that's a very easy low-hanging fruit that you can start to work on at your institution to have that better continuity of care and streamlined patient care once they get to the ICU. So Awesome, Frank. This has been great. So in part 2, we're going to dive into the SCOPE DKA trial, and this compared plasma light versus normal saline in severe DKA, which remember, severe DKA patients were excluded from this trial.
Yep, we're going to dig into chloride loads, ketone clearance, and how fluid choices might tilt recovery curve. So don't miss it.
Frank, thanks for joining me. And again, follow us on social media for awesome post summaries and Rebel reviews. If you want more evidence-based insights, subscribe to us on your favorite podcast platform and check out rebelem.com for the full blog post. And until next time, thanks for joining us, Rebel listeners.